I think the most challenging disease scenario that I encounter in my practice is the patient with multivessel diffuse disease or tandem lesions in multiple vessels. In the scenario of diffuse disease or multiple lesions in a single vessel, what is the best approach in terms of physiological assessment? On the one hand, there's the pressure wire, and on the other hand, there's a microcatheter-based system. First off, I would say that just doing physiological measurement, period, is an important thing to do in our practice, irrespective of what technology you use. Once you make the decision to do physiological assessment, then we can talk about what are the pros and cons of the different devices. I think in the setting of diffuse disease, multivessel disease, or tandem lesions, there are certain practical advantages with a microcatheter system. When we assess tandem lesions, we really need to understand the interaction of fixing one lesion with the physiology of the second lesion. We may fix the most distal lesion first and then have to reassess the proximal lesion or vice versa. And when we have a pressure wire, that would require multiple pullbacks and multiple rewirings of lesions and perhaps even having to switch out wires because of having to reshape the tip or just kinking the wires themselves. So from a practical perspective, a microcatheter allows you to go back and forth over the same wire, and when you do your pullbacks, often recheck your pullback and make sure you're hyperemic, go back and forth and really measure the change in FFR along the length of the vessel itself. So my recommended approach in assessing serial lesions with FFR is as follows, and I generally would use a microcatheter in most of those scenarios. So first would be put the wire down, your workhorse wire, advance the microcatheter. Really you want to be about 2/3 of the way down the lesion, substantially or at least past your distalmost lesion. And then give adenosine. I prefer IV adenosine. You need to use IV adenosine if you're going to do a pullback. So in the setting of tandem lesions, IV adenosine is mandatory. You then do a pullback fairly slowly, and as you do the pullback, you watch your FFR value. And you can even mark down as you pull back by cine angiography where the major step-ups are in the FFR value. Once you're done with that, you then look back and you look at what you've saved in your cine angiography in terms of where the major step-ups were, and you look at the delta, the change in FFR during the pullback at each one of those sites. So what I do first is that if there's a single area which contributes substantially to the delta in FFR, that's the lesion I would fix first. And I would stent that area, I would optimize that area with post-dilatation, covering normal to normal tissue, and then repeat the FFR. So that's re-advancing the navis microcatheter, re-equalizing at the ostium, and assessing the second lesion, and determining if there's a positive or significant FFR at that venue. Sometimes if the FFR is equally contributive for both of the lesions, I may take a shortcut and just stent both of those lesions at the outset, and that's more practically guided rather than scientifically guided. So it can be a fairly intensive process to pick out exactly which lesions need to be treated, but it is the most physiologically and scientifically sound way to move forward. So some interesting results came out here at EuroPCR, looking at post-PCI FFR with the FFR Search registry and the beginnings of the FFR React randomized clinical trial, which is looking at acting on the FFR measured after stent implantation, so post-PCI. So stepping back, FFR Search was an observational registry looking at post-PCI FFR measured by the microcatheter and looking at outcomes at 1-year follow-up. What they found were several things. First, a fairly large proportion of patients had FFR values less than 0.90. About half actually had FFR values post-PCI of less than 0.90, and about 1 in 10, 1 in 12 had an FFR value of less than 0.80. They also found that patients who had an FFR post-PCI of less than 0.90 had a numerical increase in major adverse cardiovascular events at 1-year follow-up. Now, it did not reach statistical significance. I don't think personally they had the power to see that, but there's clear trends towards that, and we'll see at 2-year follow-up whether it ends up being statistically significant. I think also they will be doing a ROC curve analysis to find out which FFR value best predicted major adverse cardiovascular events. But I do think, stepping back, despite the fact they did not reach statistical significance with their findings, there were some lessons to be learned. First off is that we need to be very careful and judicious to make sure that we treat all the lesions in the coronary tree. Don't leave lesions behind. So much like assessing tandem lesions, make sure that that indeterminate lesion you leave behind after you've done PCI truly is not physiologically significant. The other thing we learned is that perhaps an FFR within a stent, the cutoff may not be the same as FFR before doing PCI on a de novo lesion because of the mechanism of stent under expansion and thrombosis. So a lot of questions, but I think also really raised our eyebrows and really makes us emphasize optimizing our PCI results after percutaneous intervention. So my general viewpoint on optimizing PCI comes in several phases. One is optimize what you're going to treat. So diagnosis, preferably with physiological evaluation. So use FFR to determine whether to treat a lesion. Number 2 is do further imaging if necessary, and usually it is intravascular imaging to determine how to treat that lesion, covering normal tissue to normal tissue, maximizing stent expansion, getting the size of the stent distally and proximally correct. Then further optimize, and if there are tandem lesions, make sure you do the FFR. Most practically, if you're going to do post-PCI FFR, that's with a microcatheter. Do that if you see angiographic evidence of indeterminate lesions. And FFR Search teaches us that maybe we should do more routine post-PCI FFR, and whether that turns out to improve patient outcomes in the long term remains to be determined, but clearly is an exciting way forward.